Hello, I hope everyone could hear me. Hope everyone could hear me. So, I have planned to discuss cholecystectomy today. So, for a period of sometimes I have planned for a PPT, making PPT slides. Uh, what are the procedures carried out in a general surgery department mainly? I have planned to discuss. So, today I have planned to discuss open cholecystectomy, a procedural guide. So for first half an hour of my live study streams, I would like to discuss any surgical topics and operative procedures. Okay. I have planned to discuss open cholecystectomy, a procedural guide. So for first half an hour of my live study streams, I can like discuss. So let's shall we move on to the slides? So cholecystectomy. So when an open approach is indicated, so nowadays the cholecystectomy both done in both open method and the lab method. So today we will see the open approach. So when an open approach is indicated, is required approach for a range of condition, either as the primary plan or as a necessary conversion from a laparoscopic procedure. So when and all the open approach is preferred is when there is an inflammatory condition or stone related diseases. So symptomatic cholelithiasis, acute or chronic cholecystitis, choledocholithiasis, when it is resolved, also we have preferred for a open approach only. And in case of biliary pancreatitis, when it is resolved, it is also open approach is preferred. I hope the slides are visible to everyone. Okay. So, in case of the patient has taken into laparoscopic method, Also, the open, when it is a procedure becomes difficult in the laparoscopy, then it also converted into open. So conversion or contraindication to laparoscopy. The conversion of laparoscopic method to open method is more common nowadays. So conversion from laparoscopic cholecystectomy or inability of a patient to tolerate pneumoperitoneum. So in case of a patient having a COPD, majority of the times the patient is subjected to open cholecystectomy. So in other critical scenarios like a carcinoma of gallbladder, trauma, incidental to other procedures when abnormalities are noted. I am not able to visualize. Okay, hope everybody could see the letters. And the next time I will correct it. Okay, now see. First, we have to see the what are the preparation and access. It is the phase one. So, in any general surgical cases, the preparation of the patient is most important. So, the preparation, establishing the foundation for a successful operation. So, patient positioning. Patient is placed on the operating table in supine position. Anesthesia and prophylaxis. General anesthesia is induced. Preoperative antibiotics are administered. Initial measures, a Foley's catheter and nasogastric and orogastric tubes are placed, as everyone knowing it. So the matter of thing is why we have to introduce a Foley's catheter and a nasogastric or orogastric tube are placed. So Foley's catheter to decompress the urinary bladder, nasogastric or orogastric tube are placed to decompress the stomach. So the operative field is visualized easily. The timeout, a critical pass is completed to verify the correct patient, procedure site, positioning, and any special equipments. The right subcostal incision. The procedure begins with the right subcostal coccus incision. This is deepened through subcutaneous tissues with hemostasis achieved via electrocautery. The facial and aponeurotic layers are then divided to enter the peritoneal cavity. The incision is made 2 fingers breadth below the costal margins, extending from just to the right of the xiphoid to the anterior axillary line. Clearing the field for visualization. Once inside the peritoneum cavity, so before after entering the right subcostal incision, the peritoneum is entered, following which right subcostal incision, the steps are made to enter into the peritoneal cavity. So once clearing the once after the right subcostal incision, the peritoneal cavity is, yeah, inside the peritoneal cavity we have to go. So incision of the peritoneal cavity. Step 1. So the management of falciform ligament. So falciform ligament is doubly ligated with 2-0 silk. sutures, and then divided. This maneuver improves exposure of the gallbladder and hepatoduodenal ligament. Step 2. The step 2 is abdominal inspection. A thorough inspection of the abdomen is performed to assess the pathology and identify any related incidental findings. So, in step 1, we have ligating the falciform ligament. In step 2, in the abdominal inspection. Any pathology in the abdomen should be verified whenever you do laparoscopic abdomen or in open abdomen also. A walkthrough should be given. So, decompression of the gallbladder. A distended gallbladder can obscure the anatomy and increase the risk of perforation. So, decompression is often necessary before dissection can proceed. In case of inflamed or adherent gallbladder, an extensive number of adhesions of momentum and bowel to the region of the gallbladder were noted. Adhesions were laced sharply under the direct vision with Metzenbaum scissors. So, Metzenbaum scissors, I will clearly explain when I will discuss the instruments. So today, remember, so the adhesions are removed first. So if tensely distended, a purstring sutures of 30 silk was placed in the fundus and the biliary trocar used to suction the bile and stones. The trocar was removed and the bile was cultured. So actually, I am discussing from the textbooks. Majority of the surgeons do their own steps. Followed by which, so now we have decompressed the gallbladder. The critical dissection. So what the critical dissection is identifying the cystic duct and artery. So the most so when we discuss laparoscopic cholecystectomy, we will be studying about triangle of safety. So here the triangle of safety will not be mentioned here. So the critical dissection is identifying the cystic duct and cystic artery. This is the most crucial phase of the operation. With the traction placed on the fundus of the gallbladder, the peritoneum overlying the hepatoduodenal ligament is incised. The goal is to unequally identify and encircle the cystic duct and cystic artery before any ligation occurs. Essential action: isolate and encircle both cystic duct and the cystic artery individually. Wait a minute. So liberating the gallbladder from the liver bed. So first is a field of visualization. Managing the falciform ligament and abdominal inspection is done, followed by which decompression of the gallbladder is to be performed. Any adhesions or a tensely distended gallbladder, if a tensely distended gallbladder means a pursuing sutures of 30 silk was placed, the fundus and the biliary trocar used to suction bile and stones. Okay, so decompression of the gallbladder should be performed, followed by which identifying the cystic duct and cystic artery. So the word should be important: unequivocally identify and encircle the cystic duct and cystic artery before any ligation occurs. So the essential action is isolate and encircle both cystic duct and cystic artery individually. The word individually is most important. So we should not encircle both cystic artery and cystic duct. Uh, so remember separately. So liberating the gallbladder from the liver bed. So there are two techniques. Standard technique is a fundus down technique. It's a retrograde technique. Fundus down. The dissection begins at the fundus and proceeds downwards towards the cystic duct and cystic artery. The gallbladder is carefully dissected off from the liver bed. This is the primary method described in the essential steps. Okay. The antegrade dissection is the feasible alternative. So this approach begins with the dissection of the cystic duct and cystic artery proceeding up towards the fundus. So the cholangiogram is the most important thing in a the most important thing in a cholecystectomy. So the purpose of a cholangiogram is good flow of bile into the duodenum. So why we are using cholangiogram? So after introducing a cholangiogram, so the good flow of the bile into the duodenum can be visualized. An intact biliary tree can be visualized. Absence of any filling defects, a retained common bile duct stones can be easily visualized using with the help of cholangiogram. So the technique is a clip is placed on the cystic duct close to the gallbladder neck. It's a surgical clip. A small nick is made in the cystic duct. A cholangiogram catheter is threaded into the duct to inject contrast. So I have made a short gist about the cholangiogram administration. So there are several books described about how to administer cholangiogram. Let okay. Uh, so cholangiogram is optional. The definitive step, the ligation and division. Once positively identified, the cystic duct and cystic artery are ligated with a 30 silk and divided. The gallbladder is now free and is removed from the field. The critical risk. This step carries the highest risk of injury to the common bile duct or the right hepatic duct. So, uh, anyway, the bile duct injury is common nowadays in both the laparoscopic and open procedures. So, if a bile duct injury happened, they will sue you as a in court. This step carries the highest risk of injury to the common bile duct or the right hepatic duct. So, the meticulous identification, as shown in the previous slide, is the key to the prevention. So, identification of the cystic duct and cystic artery stump is very much important. So, instead of ligating the cystic duct, the common bile duct injury or common hepatic duct injury can happen easily. Phase 4, the resolution and the final inspection, securing the field before closure. So, followed by which check hemostasis. The liver bed and the entire operative field are meticulously inspected for any bleeding. Inspect ligaments. The hepatoduodenal ligament is inspected and palpated to ensure it is intact and without abnormalities post dissection. Place omentum. Omentum is laid in the operative field, the gallbladder fossa, to help prevent fluid collection and adhesions. So the placement of omentum is majority of the times is not done. So in my reference book that it was given, so I have included it. So drain placement of and abdominal closure is also a more is measure is most important in case of it is important in case of when there is a fluid collection in the abdomen, or any in case of cholelithiasis associated with cholecystitis and pus collection in the operative field. A closed suction drain is placed in the gallbladder fossa. It is secured to the skin with a 30 nylon suture. So the source notes, the source notes means the source which I have referred. The drain placement is optional. Closure. The incision is closed in layers using either running or interrupted sutures. The skin is closed with staples or subcuticular sutures. In some cases, it may be packed open. Adapting procedures. The key variations. The standard open cholecystectomy can be modified to address specific pathological findings. For severe inflammations, the back wall of the gallbladder may be left in situ on the liver bed to avoid a dangerous dissection in a severely inflamed field. Subtotal cholecystectomy. So, in case of a severe inflammation, we can plan for a subtotal cholecystectomy. In case of for carcinoma of a gallbladder, the procedure can be extended to include a portion or a regional portion. Some words are missing. I don't know what word I left. Okay, I'll say at later. So the dissection alternatives. So initially we saw the alternative dissection and antrograde resection and retrograde resection. As previously noted, from duct to the fundus is a feasible alternative to the standard retrograde approach. Understanding and mitigating potential complications. Meticulous technique is a paramount to avoiding these potential adverse outcomes. So the complications are ductal injury, sorry, not a complication, but it's an accidental ductal injury, injury to the common bile duct or right hepatic duct, bile leakage from the cystic duct stump or an accessory duct, subhepatic abscess, a collection of infected fluid in the gallbladder fossa, retained stones, retained common bile duct stones, which a cholangiogram is designed to detect. So, majority of the times, in case of cholelithiasis, also nowadays ERCP is done to check for cholelithiasis also. So, ERCP, whenever we are proceeding with the cholecystectomy, ERCP and followed by MRCP is must. Sorry, MRCP followed by ERCP is must. Sorry. So the operative goal is achieved. The dissected gallbladder is successfully removed while preserving the integrity and the function of the biliary tree. Thank you.